The NIAGARA study is a global, large, randomized phase 3 study. It was a huge undertaking of 1,000 patients in muscle-invasive bladder cancer. I think it's the biggest study we've done in perioperative disease. We've done studies in the past and struggled to recruit. So I think, firstly, it's amazing we managed to do this successfully, and that's testament to the huge team that were involved. The question's actually a very simple one. The current standard of care for muscle-invasive bladder cancer is 4 cycles of neoadjuvant chemotherapy followed by cystectomy. What we did in this trial is we added perioperative durvalumab to that. So you got the durvalumab 4 cycles before the cystectomy and 8 cycles after the cystectomy. And so a big randomized phase 3 2-arm trial, perioperative durvalumab, neoadjuvant chemotherapy, cystectomy. The patient population of the 1,000 patients was actually well balanced for the 2 groups. Similar T stages, for example, similar proportion of patients with renal function. It was similar proportion of patients with PD-L1 status, so a really well-balanced randomized phase 3 trial. When we looked at the different phases of the trial, almost everyone started the neoadjuvant chemotherapy and durvalumab, as you'd expect. 85% of patients had the cystectomy. Not all patients had cystectomy. Patient choice was the commonest reason for not having that cystectomy. 70% of patients went on to receive the adjuvant period of durvalumab. And again, the 2 arms were very balanced. So the proportion of patients in the control arm and the proportion of patients in the durvalumab arm that had cystectomy were very similar to each other. Very robust in that respect. It was an open label trial. Event-free survival was the primary endpoint. The hazard ratio was 0.68. That was statistically significant. The curves went apart and they stayed apart, which was pretty. The forest plot analysis showed the subsets all favoured durvalumab, irrespective of issues such as PD-L1 status, T stage, renal function at baseline. The overall survival results were actually similar too. 25% reduction in the risk of death, hazard ratio 0.75. Again, the curves went apart and they stayed apart. The control arm performed as you would expect. The median follow-up was 45 months, so quite a mature data set. Again, very robust there, but also robust in the subset analysis. The benefit was across the board, irrespective of the subsets of patients. And that was in parallel with the event-free survival analysis. Toxicity is an important component of this. And it was really interesting that actually there was no, using CTC criteria, which are designed for chemotherapy, not immune therapy, there was no clear increased toxicity associated with durvalumab. That's not to say immune therapy is not associated with side effects. We know that that's true. But using CTC criteria, 41% in both arms had grade 3 or more 4 adverse events. And when you look at the proportion of patients, adverse events leading to not having surgery or adverse events leading to death, very, very low, less than 1% of patients treatment-related deaths, same in both arms. So the adverse event profile was manageable, no clear safety or new safety signal. So when we looked at the detail of the subsets of the adverse events, a lot of it was hematological toxicity and chemotherapy-driven, not driven by immune therapy. The summary is this is the first time we have done a perioperative trial in urothelial cancer, and we showed an EFS and a significant overall survival advantage, which is very positive. We also have looked at before, other trials have looked at adjuvant nivolumab and adjuvant pembrolizumab. They've had positive disease-free survival, but not overall survival advantages. So it's the first time we've had an overall survival advantage in muscle-invasive bladder cancer with immune therapy. So I think that's very positive too. There's something very attractive about giving immune therapy right at the start of the journey. Waiting until the patients had chemotherapy, waiting until they've had cystectomy, and only starting the immune therapy then. Not everyone gets to that state. And so I think there's something attractive about giving this treatment early, giving immune checkpoint inhibition early, giving the durvalumab quickly, getting the patient, getting immune therapy into the patients, and then that is translating to this new survival advantage. So yeah, that's the summary of the study.